Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Welcome to Transformational Pediatrics. I'm Dr. Michael Smith, and our topic today is MAGEC rod system, minimally invasive approach to pediatric spinal care. My guest is Dr. Nigel Price. Dr. Price is the chief of the section of spine surgery at Children's Mercy Kansas City. Dr. Price, welcome to the show.
Well, thank you for having me.
So, what is the MAGEC system?
Well, the MAGEC system is a technology that's relatively new to the American market. It's been used in Europe and Asia for several years, and it's a device that's implanted onto the spine in a child less than 10 years of age with a scoliotic curve over 30 degrees by our method of measuring, who is at risk of continued progression of the curvature. And what this device has done is essentially revolutionize the historical treatment of these children's scoliotic curves, in that once it's implanted, we can remotely lengthen the rod through the skin with an activator, rather than the traditional method, which was to bring the child back to the operating room approximately every 6 months for a surgical lengthening. So it's essentially taken away these repeated surgeries, and that's quite a paradigm shift or a revolution.
And so let's review again the ideal candidate then for the MAGEC rods.
So the ideal candidate for a MAGEC rod is a young child less than 10 years of age whose spine length is less than 22 centimeters or less than about 10 inches, whose measurement or scoliosis measurement is greater than 30 degrees, who's at risk of continued progression of the curve to the point of developing a problem in our field that's called thoracic insufficiency syndrome, which is the interference or inability of the rib cage and the lungs to support work of breathing because of the presence of a curvature. So that's kind of the cohort or the group of patients who we treat with MAGEC.
And so let's talk a little bit about the historical way we used to treat this, right? So you're talking about maybe a severe curvature in a child, and you're talking about multiple surgeries.
That's correct.
To correct that. So what's the common outcome from those surgeries? Did the surgeries work? Were there complications down the line for the child? What do you think?
Yeah, so for generations, surgeons have been challenged with children who present early with curves. Small children presenting early, in some cases, a very, very rapid progression of the curve that puts the child at jeopardy for their health for their lifetime. So early attempts at casting and fusing the spine with just bone graft evolved into the early versions of what we call Harrington rods, which were hook rods that suffered from breakages and prominence. Later versions were good. However, still required multiple returns to the operating room. And is a concept that we discuss in our field. It's the law of diminishing returns, meaning that the longer these rods are in and the more frequent the surgeries, the greater the likelihood of rod breakage or migration, infection, very rarely neurological problems, and a stiff spine. And the outcome eventually with these children is that we historically did a final operation, which was a very large adult-like operation at the end of a long journey of repeated operations. So the course was difficult for the family. They were in the hospital at least every 6 months for their procedures, and if they had a complication, they had what we call an unscheduled visit to the operating room, which of course would impact their childhood. And of course it's a stressor for the child and the family. So MAGEC has really been a very nice change for that.
Sure. And so Dr. Price, when you describe it that way, when you think of, the history of treating severe curves in children, Yeah, so you're using words like transformative, and it really is when you think about what we used to do for these patients. Maybe, how about this? Can you walk us through what a patient and a family goes through at your clinic with your team, from the initial surgery and through the follow-up treatments?
Yeah. So the little boy or girl, usually school age or beyond, is the ideal candidate with a curve who has a history of progressing to over 30 degrees. And in my case, in our practice, there's 3 surgeons in my group who are trained to do this. We typically would recommend surgery when the curve is approaching 50 degrees, so quite a large curve at a young age. And we would recommend that they have the insertion of the MAGEC rods. Typically, it's 2 rods that are inserted. They're titanium, and they have a torpedo-like component in the middle of them, and they affix to the spine or attach the spine with typically screws or hooks. They come in for their operation and are in the hospital for 2 or 3 days. They have a little supportive brace initially, and then they have a follow-up, usually just a couple of weeks after, to check on their wound, and then the change in the typical course is that instead of coming back 6 months after this initial surgery for a lengthening surgically, they come back approximately 3 months later. They come to the clinic as an outpatient, and we use a little device that's held over the skin in the back. We locate the magnets in their back with a little detector, and then we just position this device. It's called an external remote controller. We push a button. There's a little noise, and they sometimes are aware of a little funny sensation, but we don't typically have to give them pain medicine. It's a tickle. These days they're using their iPad while we're doing it and smiling. And then the whole process takes perhaps a minute or 2, really, for the actual lengthening, and then we take an X-ray to confirm that we've successfully lengthened it the prescribed amount, usually somewhere in the 1/8 to half an inch, and then we discharge them. They commonly do not require any pain medicine, and we see them back again in 3 to 6 months for their next lengthening. They rarely require a revision, at least in the first 3 years, to upgrade to a larger device. So these devices can typically span the duration that they're needed until they're old enough to replace them with a permanent rod, which happens typically over the age of 10.
So obviously, right, we're improving outcomes here because we are decreasing the number of invasive procedures, and that's always good in medicine, right? So, but let me just ask the question: how are you improving outcomes? What have you found so far?
Well, so far, we've done about a dozen at Children's Mercy now, and that we found that very typically the parental and the patient satisfaction, the level of anxiety that I used to see, and I still see with the kids who are doing the conventional treatments, is much less. So really, just from a patient anxiety and anticipation level, we're already seeing an improvement. From an economic perspective, the impact on the family, taking time off from work, traveling to the hospital, sometimes the patients historically we have to stay overnight if they had other medical issues, that's really gone. So the impact to the family and the impact to, whoever's paying that bill is less. And so generally we're seeing both the patient satisfaction and early signs of the economic benefit of this process.
What do you think the future of this type of technology is? I mean, does this have application in other conditions? I mean, where do you see this going?
Absolutely. I think that the necessity being the mother of invention, that applies definitely to medicine and medical applications. And in fact, there's a version of this device called a precise implant, and it's used in long bones, femurs, usually the thigh bone, where it's implanted, and rather than the external frame that's been used historically to lengthen femurs, we now have a version of this magnetically driven lengthening device that can be implanted in long bones. So that's actually out there. So there already is a sister component or a sister version of this technology. So So remote activation of devices is out there with good success in areas that had sticky problems for clinicians, as well as the impact on the families. So we could certainly see this in other areas where there's deficiency in tissue or deficiency in bone length. So I think our imagination just needs to be brought to bear, and I think there's lots of potential for this.
Dr. Price, this is fascinating stuff, and it really is transforming pediatric medicine. And so thanks for the work that you're doing. Good luck, in using your imaginations for this kind of technology in the future. I think you're spot on. And thanks for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.